Good afternoon, everyone. I'm actually presenting this presentation on behalf of Dr. Asnani. This topic holds a very special place in my heart. It's many times pregnant women, there is a running joke amongst the nurses that if somebody is pregnant, they'll likely see me. I don't know why, but I tend to see a lot of pregnant women. Before I came to Sickle Cell Unit, I used to work at Spanish Town Hospital, and I remember some of the cases that stood out to me were the ladies that came in with sickle cell disease that were pregnant. Many times they spoke about the stigma. It's as if they were being blamed for being pregnant. As a mother, I had no risk factors for a complication of pregnancy. And I suffered, I had an abruption with my first child. That is when a big clot forms in the placenta, and that my child ended up being in the special care nursery for a few days. That changed my whole perspective of how I looked at pregnancy. A woman has the right to choose what they want to do with their body. And whether she has a chronic disease or not, I really think that as a healthcare worker, we don't have to agree with her decision, but we need to support her in order to have her achieve a safe pregnancy. So I encourage you, if it is that you go and you have a negative experience, take that as an opportunity to report and have that person educated, because it is pregnancy is a risky thing. But I believe that if it is that you have a chronic illness, you should have the right to choose whether you get pregnant, and you should have the right tools and the persons to support you. So this presentation is entitled, "The Woman with Sickle Cell Disease, Do I Get Pregnant?" Sickle cell disease can cause unique problems in women: delayed puberty, more painful crisis during periods, pain during sex, problems getting pregnant due to sickle cell disease treatment, increased complication in sickle cell disease during pregnancy, and problems during pregnancy for you and the baby. It is a known fact that young ladies with sickle cell disease go through menarche at a later time in their life as opposed to their counterparts. On average, persons with sickle cell will have their period between the ages of 15 to 16 as opposed to their AA counterparts that have their menarche at 13 years old. You see more, we'll take questions after. Oh, sorry. Menarche is the first period. Sorry about that. So menarche is the first period. You find that persons with SS or severe forms will have later periods than persons that have milder forms such as SC and S-beta thal. Some persons report menses to be irregular, or they may be heavy and associated with pain. I've had patients that will tell me that they know when if the period is irregular, they know when their period is coming because they start to get bone pain. And that is something that has been well reported by patients with sickle cell disease. Are women with sickle cell infertile? Early reports would speak to premature deaths. The average life expectancy for persons with severe forms of sickle cell is about 45 years old. So it's not a matter of they are not fertile, but they would die in the childbearing period in their life. The first pregnancy normally occurs 4 years later than women without sickle cell disease. And it may be due to delayed periods, delayed initiation of sexual activity, less sexual contacts because of frequent hospitalization, or just the parents being very protective, different lifestyles, or less stable relationships. Contraception is critical for women with sickle cell disease. However, patients, especially girls and women, have low interest in seeking contraception. So contraceptive use among sickle cell disease, ladies with sickle cell disease, is low. And that is very concerning. You know, when you think about the presence of mortality and morbidity, as in death and complications related to sickle cell disease, is 7 to 11 times more likely to occur in a woman with sickle cell disease. Pregnancies must be planned for everybody, but much more with persons with sickle cell disease. So contraception is actually a part of practicing wellness. So I'm not going to tell you not to get pregnant, but your pregnancies must be planned. Despite popular beliefs, all common methods are acceptable. Any risk which is possible with a woman that does not have sickle cell is also any risk possible is much less when compared to possible complications of pregnancy. You have several options. So the Depo-Provera, which is the injection. You have the intrauterine device, which is the coil, or the copper T or the Mirena. Mirena is a hormone-based coil, while the copper T is a copper-based, is non-hormonal. Oral contraceptives, and there is no increased risk of clots as compared to the general population when you're on oral contraceptives with persons with sickle cell disease. And other devices such as the Norplant or J-Del, which has been shown to decrease painful crises. Pregnancy in a woman with sickle cell disease can affect mother and her baby. In terms of maternal complications, you can have more painful crises, increased risk of urinary tract infection, lung complications such as acute chest syndrome, anemia, preeclampsia, which is high blood pressure in pregnancy, and we have to discuss there's a risk of death. For baby, there is the risk of having a premature baby, because if it is that you have preeclampsia, which is a high blood pressure in pregnancy, to cure preeclampsia, to get the pressures down, to prevent you from having a stroke, they have to deliver the baby. So the baby may be not term, so baby may be less than 37 weeks, but to save your life and to save the babies, that they may have to deliver the baby in the at 34 or 33 weeks. Low birth weight, and that may be explained by there is an abnormality in the placenta for mothers with sickle cell disease that have preeclampsia, fetal distress during labor, and higher risk of death in the baby. These are just a few of the complications. There is an increased risk of stroke, and that's related to the increased risk of high blood pressure during pregnancy. There is a risk of 61% increased risk of infection. There is a 25% increase in miscarriages, risk of pelvic inflammation, risk of papillary necrosis, which is a complication of the kidney, increased risk of meningitis, increased risk of bone crisis, increased risk of inflammation of the amnion, which is the fluid that the baby is in, increased risk of acute chest syndrome, and decreased placental weight, and increased risk of placenta previa, which is abnormally low-lying placenta. The total maternal death over the past 10 years, between 1998 and 2007, there were 418 deaths reported. 10% of these deaths occurred in persons that have sickle cell disease. So one of the persons that die, for every 10 women that die in pregnancy, one of them will be a sickle cell patient. One of my best friends, she's an anesthesiologist, and I remember at the height of the flu outbreak last year, she was saying to me, we really need to talk to the ladies at Sickle Cell unit and educate them more about pregnancy. And she was saying half of the persons that were in the ICU at the time were women with sickle cell disease. And she was saying that not to discourage them from getting pregnant, but many of them didn't have the flu vaccine. Many of them sought antenatal care late. And those factors, adding to the fact that you have sickle cell disease, put you at risk for poor outcomes. As it relates to painful crisis, bone pain especially increases in the 3rd trimester, which is the final stage of pregnancy, and immediately after delivery. In Jamaica, it was noted to be 5 times pre-pregnancy in the 3rd trimester and in the postpartum. So we monitor women when they come in and a sickle cell delivery, a person with sickle cell delivery, and we monitor these patients closely. Most persons that have sickle cell disease, once they present to the sickle cell unit, we refer them to a high-risk clinic. So once you're pregnant with sickle cell disease, you're referred to a high-risk clinic. And in a high-risk clinic, it is a multidisciplinary clinic. So you don't have just the gynecologist, but you have other members. So remember earlier I was saying that persons with sickle cell have a risk of heart complications, have a risk of kidney complications. We want you to attend a clinic that has cardiologists. Pulmonology should be a multidisciplinary team that is managing your pregnancy, and the earlier you come, the better. Delivery can be normal, so you don't have to have a C-section. C-sections are indicated as per the general population. So how do we manage a pregnancy? How do we manage a sickle cell pregnancy? Management begins before the patient gets pregnant. So I always joke with when people come and ask me, doc, I want to have a baby. And the first thing I would ask them, tell me about the man. Like the first thing I say to them, tell me about the man. And I'd ask, is he working? Have you tested him for sickle cell disease? Have you seen his HIV results and his syphilis results? Has his genitals been inspected for wart? All those things I tend to ask my patients, because you have patients that present and they look well, and when you do the test they have HIV. So we don't want to add sickle cell pregnancy plus HIV. You want, as you meet the person and you even continue to say this person could be the father of my children, and you start matching up your last names, carry them to the unit and say, come, get tested, let us see if it is that you have sickle cell disease. Carry them to them doctor, let them do them HIV test, and you see the results, syphilis results, and you screen them for HPV. So pre-pregnancy care, the doctor needs to have a discussion about the risk to the mother, the risk to the baby, partner testing and genetic counseling, and the low threshold for seeking medical care. Ensure that you have baseline bloods. So remember I said baseline bloods, complete blood count, liver function, kidney function test, urine test. Those are important so that we can know your steady state, so that we can have something to compare. And if anything goes wrong in the pregnancy, we can say, okay then, her hemoglobin was 10 before, it's falling, it's at 7. We expect in pregnancy at some point the hemoglobin fall, but if we notice a big fall, we can monitor you more closely. We want to also document the size of the spleen, because you can get acute splenic sequestration in pregnancy. All the crises that you can have when you're not pregnant, you can have it while you're pregnant. And we want to monitor you closely, because pregnancy is a very sensitive time. We want to determine the state of your organs, especially your heart, your kidney, your lungs. We want to give nutritional advice. Start folic acid. So even before you conceive, remember the baby's brain and spine is formed within the first 6 weeks. So if you start taking the folic acid it helps in the development of the brain and the spine of the baby. So if you start to take it after the fact that you found out you're pregnant, where most people present after the 6 weeks, the baby brain and spine are already formed, right? So we want to start taking that folic acid before. We want to ensure appropriate vaccinations. So we want to get our flu shot. We want to get our H influenza type B shot. all the things that can cause pneumonia. We want to ensure pneumococcal, the same Prevnar, PCV, the pneumovax. We want to ensure that you have those vaccines, because some of them cannot be given in pregnancy. So even before, we should cover ourselves. Reassess medications. If you're on hydroxyurea, we want you to stop it for at least 3 months, because there has not been much testing as to the effects on the fetus while on hydroxyurea. And if you're on kidney medication such as enalapril, lisinopril, any of the ACE inhibitors, any of the ARBs, you come off those medications before and we explore another option. In terms of antenatal care, as I said before, multidisciplinary team is critical. We want to ensure that you're seeing a high-risk obstetrician, and we want you to come into the clinic so that we can do our assessment. Avoid dehydration. If you have vomiting is a regular part of pregnancy, but when you're vomiting and you have sickle cell, that can lead to dehydration. Come in, do not watch it. Come in, let us assess you, let us give you medications to help, let us advise you. Avoid overexertion. So if you know you're working a very stressful job, ask if you can have the duties, transferred or take some time off. Continue on your medication, the folic acid, start your prenatals. Extra iron is only indicated if you have iron deficiency anemia. So if you're not iron deficient, you don't need to start on iron. Prenatals having the adequate amount of iron that you need for your pregnancy. In the second trimester, we want to start you on folic acid, and that has been shown to reduce the risk of preeclampsia, eclampsia. Aspirin, low dose aspirin. Careful what pain medication you take. So during that time, we don't want you to be taking a lot of the opioids. So the morphines, the pethidine, remember, some of those things can cross over to the placenta and affect the baby's developing brain. So be very careful what medication you choose. If it is that you have kidney problems, don't load up on the Voltaren and the Cataflam. Those can affect the kidneys, and remember that the baby is sharing the kidney to get rid of the baby's waste. So if it is that you are stressing your kidney with these drugs, that can affect the baby, and it can also affect you. Keep your routine visits. If they say you should come weekly, go weekly. They say go every 2 weeks, you go. In the first trimester, it's usually weekly or fortnightly visits in the first, the first and the second trimester. Weekly visits after the second trimester. Every visit you should have your blood pressure taken, weight is generally done, urinalysis to check for if there's any protein or blood, because this can be signs, especially if the pressure is high, of preeclampsia. We want to do complete blood count and reticulocyte count. We want to do an echocardiogram, that is an ultrasound of the heart at the third trimester, because remember, pregnancy, the blood volume expands, and if it is that you have anemia, that is going to stress the heart, and the heart will have to work harder, and sometimes the heart can fail during pregnancy. So we want to do an echo to ensure that the heart can manage the pregnancy. And we want to ensure that you do an obstetric ultrasound to see what the baby looks like, what the placenta looks like, all of the things that are happening with the baby. Education and counseling is very important. Don't be afraid to ask your doctor questions. Even if it's a question that you may be embarrassed about, there are some women that are not supposed to be having sex during pregnancy. If you are unsure, ask your doctor. Not your friend that think they know. Ask your doctor. Plan for delivery no later than 38 to 40 weeks of gestation, and discuss options for pain relief during labor and delivery. And this is very, very important. Discuss risk of complication after delivery, such as painful crisis, postpartum depression, and acute chest syndrome. Sometimes transfusion may be required for really ill women and for women who have very low hemoglobin. So I encourage persons not only to have donors, but have donors that have your blood group. So if you know your blood group from your antenatal screen, go out. Anybody have O positive blood, I am going in, because it doesn't make any sense you go and you get somebody that is B positive and you are O positive. That blood, yes, it will benefit the general public, but when it is critical and there's lots of B positive blood and no O positive blood, you will be there. So seek matched donors. In terms of labor and delivery, proceed to full term unless other problems. Hospital delivery is strongly encouraged. Remember that complications can occur during pregnancy and after pregnancy. So a sickle cell pregnancy is not one that we're going to encourage to have a doula at home and a home delivery and a water birth. This is the type of pregnancy that if we need ICU, we can get there quickly for the baby and the mother. We want to have a cross-match blood available. We want to have an area that has fetal monitoring, adequate hydration, and if we need to do a C-section, we can go, right? Some people, we may encourage them to start chest physiotherapy before because they may be at increased risk. Some persons have a high risk of acute chest. So for those persons, we may say before they go into delivery, we start them on some chest physio the day or a few days before. Antibiotics may be needed as it is needed, but we don't put you on prophylaxis antibiotics unless it is needed. The baby should be screened. Well, once the baby is born, we should ensure we screen the baby for sickle cell disease. Sometimes, depending on where the baby is born, so if the baby is born at a private hospital, you should ensure that when you leave with the baby, you take the baby to the sickle cell unit where we can test the baby for sickle cell disease, especially if you don't know your partner's genotype. Proper fluids, very important. Keep hydrated. Get up out of bed early. Some people say, boy, the doctor wicked as me deliver. But that's important because in the postpartum period, you're at risk for clots. We want to ensure that care and vigilance as the pain occurs, don't be shy and say, boy, I don't want to complain because I hear the lady down the bottom crying. Let your doctor know if you're in pain. Because when you're in pain, you're not breathing properly, you're not breathing in deep, you're not oxygenating the base of the lungs, and you can develop acute chest. So if you're in pain, let your doctor know. Encourage breastfeeding. They say breast is best. Follow up 1 week after, 6 weeks after, and monitor up to 1 year. Begin contraception 6 weeks after. Believe it or not, I've seen situations where mommies come at 6-week clinic pregnant, and you can just imagine you are a sickle cell patient and you just go through this stressful pregnancy and then you come back pregnant. Your body has not recovered. Your body will take up to a year, sometimes up to 2 years to recover from the pregnancy. So if it is that you know that you and your partner have a very good chemistry, ensure that you begin your contraception after the 6-week visit. So in summary, sickle cell pregnancy is a high-risk pregnancy and might affect the mother and the baby. Sickle cell pregnancy can be successfully managed with a prompt and aggressive multidisciplinary approach, joint obstetrics and hematology and sickle cell expert outpatient and acute inpatient reviews, close monitoring of the baby and mother, and simple management strategies for common severe complications such as acute chest syndrome and acute pain episodes. Thank you very much.